All right, Chapter 49, Thoracic Trauma. Thoracic injuries directly account for about 20 to 25% of all traumatic deaths. And, depending upon the resources that you look at, some people will say that thoracic injuries are the number one cause of traumatic death, where other resources will say head injuries. They kind of go back and forth. But the interesting thing about thoracic injuries is that only about 12% require surgical intervention. The vast majority of thoracic injuries can be managed without taking them to an OR. The most common cause of injuries leading to accidental death in the United States is motor vehicle crashes, and that constitutes the vast majority of all our trauma that we respond to, whether it be head injuries, thoracic injuries, abdominal injuries. The most common is the result of a motor vehicle collision. When we look at chest wall injuries, it counts for more than 50% of all blunt trauma cases involve the chest. And when you think about blunt trauma and the sternum and all the ribs, and how a person might receive a blow to the chest, particularly if unbelted in a motor vehicle collision, you can understand why chest wall injuries are very common with blunt trauma. And then you also have to keep in mind what's inside the chest. The broken ribs are one thing, but in that mediastinal space, you've got the heart, you've got the 8 great vessels, and you have a brachial plexus as well as the 8 great vessels. And you can see in relationship to the clavicle that the subclavians run on top and then dip under the clavicle as they make their way down the arms. Also in that chest, you've got your lungs as well as the heart and the 8 great vessels. Rib fractures are the most common significant chest injury. 4th to the 9th are the most commonly fractured because they're thin and they're poorly protected. And it's usually the lateral part of the 4th to the 9th rib. 1st to 3rd, if you've got fractured ribs, 1st, 2nd, or 3rd rib that are fractured, suspect a high velocity trauma. It takes a tremendous amount of traumatic injury to fracture those ribs, and the 1st rib is actually tucked up under the clavicle, so you don't even see the 1st rib. That's kind of hidden up under the clavicle. The 1st rib you palpate is actually the 2nd rib. The 9th to the 11th rib suggests an intra-abdominal injury as well. 11th and 12th are free-floating ribs, and certainly if 11 and 12 are fractured, there's always a potential for laceration of the liver or spleen. And that's what that point says, that left lower rib injuries, particularly on the left, are going to lead to splenic injuries. On the right, you're looking more at liver injuries. The posterior rib fractures, the 5th to the 9th, are the most frequently fractured because the 5th intercostal space is right at about the nipples, which is right about where your scapulas end. So your scapulas do a really good job of protecting those first 5 ribs, but when you get below your shoulder blades, then those ribs back there, 5 through 9, are not as well protected, and that's why they're the most frequently fractured posteriorly. You get to lower posterior rib fractures, you also got the spleen, but then you got to think about the kidneys that stick up under those, the T12 and 11 and 10. When you have an open rib fracture, you know that you'll be dealing with a visceral injury because along the bottom of every rib runs a nerve, an artery, and a vein. And while we don't often think about it, if you've got a significant 2 or more rib fractures, you have not only the potential for an internal injury to the vital organs they protect, but also if I've got 5 ribs that are fractured, I potentially could have 5 intercostal arteries that are torn, as well as veins. And trauma surgeons will tell you that one of the leading causes of thoracic trauma death is exsanguination from multiple rib fractures. In addition to the potential for bleeding, you also have to deal with atelectasis. And atelectasis is the collapse of the alveoli. Patients are not going to want to take a deep breath if they have rib fractures. They're not going to want to take a good, strong, forceful cough. And over time, certainly with hypoventilation and an ineffective cough, not able to clear the secretions well, they do increase their risk of pneumonia. To know whether or not somebody has a rib fracture, you're going to do your history of the mechanism as well as examine the chest, looking for decap BTLS. Tenderness, bony crepitus, bruising, muscle spasms over the ribs. They can point to where the fracture is. And of course, the pain gets so much worse with movement or any sort of deep breathing or coughing. What you might see them be doing when you arrive, if they have rib fractures, is to splint it themselves. They may be holding their rib cage, or they may take a pillow and push it against that fractured rib site. Antero-posterior pressure that also elicits pain is a potential physical finding for rib fracture. Again, I'm not so much concerned about the broken rib. It's the damage underneath. You got to be really careful and monitor their respiratory status because they're not going to want to take a deep breath due to pain. If their vital signs support it, you certainly can give them something to relieve the pain. Make sure or encourage them to take deep breaths and cough when they need to. Monitor their pulse oximetry, monitor their capnography, and if necessary, provide positive pressure ventilation if they're hypoxic and oxygen doesn't improve their SATs, or when you encourage them to breathe deep or rapid, the oximetry doesn't come up. We used to put bands around the chest in order to splint the rib fractures. Used to actually lay a 12-pound sandbag over the fracture and tape it around the chest. Restrictive devices just decrease the ability of the chest to rise adequately and can lead to problems. So no bands or belts or anything like that for the rib fractures. Again, if you vital signs will support it, there's absolutely nothing wrong with giving some opiate analgesics for pain. Sternal fractures and dislocation of the sternum is caused by an anterior blunt blow to the chest. It results from severe hyperflexion of the rib cage, often associated with a rapid deceleration compression injury, like in the unbelted passenger that slams into the steering wheel and impales himself on the steering wheel. Sternal fracture and dislocation carries a relatively high mortality rate because of the damage done underneath. Directly under the sternum, you have the heart. So you can end up with a myocardial contusion. You can end up with a ventricular rupture, flail chest, massive pulmonary contusion, disruption of the great vessels, even intra-abdominal injuries, as well as head injuries. History of sternal fracture and dislocation. Some of the physical findings you'll see. The history is going to be they impale himself on the steering wheel, or they received a blow or a very powerful kick to the center of the chest. Your primary concerns are going to be the potential for a myocardial contusion or cardiac rupture or pericardial tamponade or a pulmonary contusion. Of course, they're going to have point tenderness, crepitus, deformity, and a lot of pain over the sternum itself. We'll talk more in detail about the assessment, management, and of a myocardial contusion and a tamponade and a pulmonary contusion in just a bit. Your assessment findings, you're going to have that history of a blow to the anterior chest. They're going to have localized anterior chest pain, point tenderness over the sternum, maybe some soft tissue swelling around the sternum. You may be able to palpate deformity or crepitus. Obviously, if they've got a pulmonary contusion. They're going to be tachypneic, not only from the contusion, but they're probably going to be hypoventilating, not taking very deep breaths because of the pain. So they're going to have to increase their rate to compensate for that. If you hook them up to a heart monitor and they do have a myocardial contusion, you're going to see potentially ECG changes as you would with any myocardial injury. You could see ST segment elevation, that sort of thing. Some therapeutic interventions for sternal fractures and dislocations. Much like rib fractures, monitor their pulse oximetry, their capnography, cardiac monitor, opiates for pain control if their vital signs support it, and you may have to assist their ventilations if they are unable to take deep breaths. Here is just a CT slice and a CT scan. On the bottom here, you can see the vertebrae, and in here you can see the heart, and across here you can see a fracture of the sternum. Flail chest is when you have two or more adjacent ribs fractured at 2 points, and this free moving segment may move in paradoxical motion with the rest of the chest. So as the chest rises, it appears to sink in, or as the chest collapses, it appears to puff out. Initially, you're not going to see that because the intercostal muscles do a good job of splinting that flail. But when those intercostal muscles tire sometime after the injury, then you'll start to see that paradoxical motion. Flail segments are commonly associated with a pulmonary contusion. And that's our concern, is that if I've got a large chunk of lung, and typically the contusion is quite a bit larger than the flail segment itself. So if I've got a portion or a major portion of a lung that's bruised, it's not going to play in gas exchange. There may be issues with alveoli full of blood, those sort of things. So our concern with flail segment is that pulmonary contusion. And here there are just a couple pictures of a potential flail segment. Of course, a lateral flail on the left, and then a complete separation of the sternum from the rib cage on the right. Here, what they're attempting to illustrate, and not very well, is the paradoxical motion that you would see with the flail segment when the intercostals are tired and unable to splint that segment anymore. Your best vantage point for seeing a flail is standing at the patient's head and looking down at both sides of the chest. That's going to be your best vantage point for actually seeing a flail segment. Standing off to one side, it is a little difficult to see. And I believe I did show you some flail segments in class. Otherwise, you can YouTube flail segment, and there are quite a few really good videos out there. Again, the physical findings you're going to have with flail include the underlying pulmonary contusion. The chest may be bruised. The patient may be in respiratory distress. You may see the paradoxical chest wall motion. Pleuritic chest pain is just pain with inspiration. Crepitus, if you palpate. Pain and splinting on the affected side. And of course, if they're hypoxic, that's going to cause tachypnea and tachycardia. Therapeutic interventions for flail: give them high flow oxygen, hook them up to a cardiac monitor, pulse oximetry, end-tidal CO2, and that's where you might monitor them for respiratory failure. If administering oxygen by mask doesn't improve their SATs or their end-tidal CO2s are extremely high, you're going to need to intervene, maybe first with pain management if their vital signs support it, encourage deep breaths and coughing, and if that doesn't work, positive pressure ventilation, and if that doesn't work, endotracheal intubation. Non-penetrating ballistic injuries can occur as the result of wearing body armor. The body armor certainly will protect them from the bullet penetrating their chest, but the impact on the body armor is like receiving a significant blow to the chest. So they can produce significant injury without penetration. Can damage the heart, the liver, the spleen, the lungs, and the spinal cord. Non-penetrating ballistic injuries. Once you remove the Kevlar vest, you're going to see some redness, some bruising, some marked tenderness to palpation. Palpate the surrounding structures for subcutaneous emphysema, crepitus, bony step-offs, and you would treat it like you would any chest trauma, depending upon where the injury is. Highly suspect a contusion or a pulmonary contusion or a myocardial contusion or damage to the spleen or the liver. Traumatic asphyxia occurs when a heavy weight is placed on the chest. And when a heavy weight is placed on the chest, all the blood in the chest is pushed out to the lower trunk, but also up into the head. And when the blood is pushed up into the head, it engorges the capillaries, and they have a tendency to rupture. If a person can get the heavy object off their chest, then they may survive this traumatic asphyxiation. You'll see petechia, facial edema, subconjunctival hemorrhage, and maybe even a deep purple skin or a color of the head and neck being deep purple. They die because they can't take a breath. It's caused by severe compression of the chest, by a heavy object, backflow of the blood from the right heart to the great veins to the head and neck. The pressure is transmitted to the capillaries. They become engorged with blood. The blood stagnates and the skin becomes purple. Traumatic asphyxia is a benign condition. In other words, if the heavy weight is lifted off their chest, then what you saw in that previous slide of that gentleman who was alive, that is self-limiting. It could, however, cause a possible intrathoracic injury, rupture of the ventricles, fractured ribs, punctured lungs, liver, spleen, all those things. So chest wall and pulmonary injuries are most common with traumatic asphyxia, and they can have visual disturbances from the vessels in the eyeball actually rupturing and bleeding. There'll be cyanosis to the face and the upper neck, jugular vein distension, facial swelling or hemorrhage of the conjunctiva. Skin below the compressed area remains pink. Hypotension when the compressive force is released, and obviously there'll be a compressive force. Therapeutic interventions is they need to be taken to a trauma center even if they are okay. Give them the high flow oxygen, cardiac monitor, pulse oximeter, end-tidal CO2, IV access. In other words, treatment is supportive. Do what needs to be done to manage the ABCs. And if the patient survives, then they should be evaluated at a trauma center. Subcutaneous emphysema is presence of air in soft tissue space. You can have subcutaneous emphysema in the neck, up around the head, the face, all the way down to the groin, the scrotum, can fill up with air. Subcutaneous emphysema is often associated with a pneumothorax. You'll feel a crunching sensation on the chest wall when you palpate it. It'll be the result of an esophageal tear from a penetrating injury, produces a pneumomediastinum. When you have massive amounts of air that accumulate under the skin, it can be extremely uncomfortable for the patient, but it is not the air under the skin itself is not the life threat. It might be not being able to oxygenate your patient, hemorrhage, all those sort of things. Therapeutic interventions, if they have subcutaneous emphysema, understand that it could be a pneumothorax, could be a torn esophagus, could be a torn trachea. Pulmonary contusion is a direct bruise of the lung tissue. Bleeding and edema occurs in the alveolar space. You get a buildup of blood and fluid and inflammatory components in the alveoli and in the lung tissue itself. And this is going to impair oxygenation. It's going to lead to respiratory distress. And it takes a great deal of force to cause a pulmonary contusion, just like it takes a great deal of force to fracture a rib. You're going to have varying degrees of contusion depending on the mechanism. So the shortness of breath is going to vary depending upon the size and the seriousness of the contusion. You may hear crackles when you listen to lungs. You may have diminished lung sounds when you listen to lungs. There may be no breath sounds over the affected contusion, particularly if it's full of blood and no air exchange is occurring. Pulmonary contusion is associated with rib fractures, so they may have some rib fractures as well. Your history and physical findings concerning pulmonary contusion. It's caused by blunt trauma, so you may see hematomas, bruising, tenderness, abrasions, lacerations. The patient's going to be tachypneic and tachycardic because they're going to be they're going to be hypoxic. So they're going to be tachypneic, tachycardic. Because of the blood in the alveoli and the blood in the bronchi, they're going to have the need to cough, so they may be coughing up blood. And of course, if they're shocky at all from hypoxia or blood loss, and the fact that they're coughing blood up would make them very apprehensive. They will have respiratory distress, shortness of breath, cyanosis, chest wall bruising, and these symptoms all are going to depend on the size and the seriousness of the contusion. Don't focus on more dramatic injuries and overlook a pulmonary contusion. If you've got other injuries that visually are more you're more drawn to, like that flail chest. Don't focus on that flail chest. Understand that underneath that flail is a very large pulmonary contusion. The patient is hypoxic. They need high flow oxygen. You need to monitor not only their oxygenation, but their ventilation. So pulse oximetry and capnography are very important. Gain IV access and transport to a facility. A pneumothorax is an accumulation of air in the pleural space. So that space between the lung and the chest. You've got your visceral pleura, which covers your lung. You got your parietal pleura, which covers your chest wall. And those two pleura are stuck together. They're stuck together pretty tight. There's a little bit of liquid in there that kind of lubricates those pleura as the lung expands and contracts inside the chest. But that space can be occupied by air from a rib fracture, from a bleb in the lung in a COPD patient where the lung just ruptures, and now every time air goes into the lung, it escapes out into the chest. It's a very common complication associated with chest trauma. In fact, it's present in 15 to 50% of all penetrating chest trauma. A simple pneumothorax occurs when no communication with the atmosphere exists. The mediastinum and the diaphragm has not shifted as a result of air, so you don't have that mediastinal shift. Once you're looking at things like a mediastinal shift, that's more associated with a tension pneumothorax. Simple pneumothorax is often managed quite well and heals on its own without much intervention unless it extends and gets larger. And that's what that first bullet part talks about. With a simple pneumothorax, small tears may resolve on their own. The patient's going to be tachypneic, tachycardic, be in respiratory distress. It takes about 25% of a lung collapse before you actually hear diminished breath sounds on the affected side. So if you're hearing absent breath sounds on the affected side, that's a good indication you've got a significant collapse of the lung. If you're into tapping on the chest, you may hear a hyperresonance when you tap on the chest, indicating the chest is full of air. You'll have decreased chest wall movement on the side of the pneumothorax. Again, difficulty breathing. They may get referred pain to the shoulder or the arm on the affected side as well, and it may hurt to take a breath. Therapeutic interventions include oxygenation and ventilation, monitor pulse oximetry, entitle CO2, hook them up to a cardiac monitor, gain IV access, and if the pneumothorax is the result of significant spine trauma following your normal assessment process for spine injury, you may stabilize them. So here there's an example of the lung on the right because looking at the patient, that would be their right lung. You can see that it is collapsed, and that as air goes in the trachea, it escapes out that collapsed lung and fills that chest wall, fills that chest cavity, causing the lung to collapse. An open pneumothorax is when the chest wall is penetrated. That's when there's an opening to the atmosphere, and air enters the pleural cavity, the lung collapses, and you're going to note a defect in the chest wall with an open pneumothorax. You're going to see a hole. To and fro air motion out of the hole. Penetrating injuries to the chest may seal itself, but it may not. Depending on the size, it may seal itself just fine. Otherwise, it may remain open. If the hole is larger than the trachea, you're going to hear a sucking chest wound. But if it's a very small hole, you may not hear anything move in and out of that hole. Especially if I had a patient one time that was stabbed about 11 times in the back, and they were using a little 1.5-inch pig sticker, and that wasn't even deep enough to penetrate into the chest cavity. So even though they had multiple holes in their chest, none of them actually penetrated through the cavity and into where the lungs were. If they do have an open pneumothorax, they're going to be tachypneic, tachycardic, in respiratory distress, may have some subcutaneous emphysema around the hole, and decreased breath sounds on the affected side. A hole in the chest is a life threat. So you need to put an occlusive dressing on. This says tape 3 sides. PHTLS will tell you tape 3 sides, tape 4 sides. It doesn't matter. The trend is you tape it down, understanding that once you tape it down, it may seal itself. In which case, they talked about if you tape 3 sides down, then if pressure builds up in the chest, it'll burp itself. If you seal 4 sides and the patient gets worse, then you have to relieve one side so that you can burp the chest. The hole may seal itself, and your intervention would not be to burp it or remove the dressing, but to do a needle decompression. So put an occlusive dressing on, oxygenate and ventilate, monitor their status with pulse oximetry, cardiac monitor, capnography, gain IV access, and again, if the assessment warrants mobilization for the spine, then do so. Watch closely for the development of a tension pneumothorax once you seal the hole. And here's an example of a open pneumothorax. Now, when you do a needle thoracotomy to decompress a tension pneumothorax, you create an open pneumothorax. Tension pneumothorax is a progressive accumulation of air under pressure within the pleural cavity. As the air pressure builds up on the side of the tension, the contents in the chest are going to start pushing to the opposite side. That's going to put some pressure on the 8 great vessels, and that acts as a one-way valve and prevents bilateral communication. The pressure inside the chest continues to increase with every breath, and at some point the pressure in the chest is so great that it does collapse the superior and inferior vena cava, causing cardiac arrest from getting no blood to the heart. Air enters on inspiration, it can't exit, compresses the vena cava, you get a decreased filling of the heart, decreased cardiac output, drop in blood pressure. You've got one lung that's not playing in gas exchange, so hypoxia is prevalent. Patient will be in respiratory distress, may show signs of shock if you've got compression of the vena cava. It can progress to prevent the heart from contracting by the pressure being so great that it squeezes the heart itself and doesn't allow it to compress. In any case, if left untreated, the patient will suffocate. Your assessment of a tension pneumothorax, they're going to have a hyperinflated affected side, poor ventilation, even though their airway's open. They're going to be restless and agitated. if you're ventilating the patient, you're going to find out that they become harder and harder to ventilate. They're going to be in respiratory distress, have some jugular vein distension. They may have decreased or absent breath sounds on the affected side. They may have tympany or hyperresonance to percussion on the affected side as well, like a big kettle drum if it's full of air. They'll be tachycardic later in the stage of a serious tension pneumothorax. They'll develop signs of shock, pale, cool, clammy skin, falling blood pressure, rapid pulse. The trachea may deviate away from the side of the tension pneumothorax, but that's a very late finding. They may be cyanotic. They may have bulging of the intercostal muscles, a narrowing of pulse pressure, and subcutaneous emphysema. Treatment is to give high flow oxygen, monitor everything that you're supposed to monitor, pulse oximetry, cardiac capnography, gain IV access. But what they need prior to all that other stuff is that once you've done an assessment of their breathing and determined that they potentially have a tension pneumothorax, then you need to do an emergent needle thoracotomy on the affected lung. Here they've done a sucking chest wound. Here's a chest that has a wound in it, and they've used an occlusive dressing to seal the wound from their IV start kit. And here they're just showing I think they're attempting to show that air can come in and out of the hole in the chest, and air can continue to come in and out of the damaged lung, which builds up intrathoracic pressure and causes a mediastinal shift. To do a needle decompression, you take standard precautions. You prepare all the necessary equipment for a needle thoracostomy. And, we used to stick a lot with IV Gelcos, and then it was determined that, that's just not long enough. The current recommendation is to use at least a 3-inch needle. You can put it on the end of the syringe if you want. This is a Heimlich valve that would act as a flutter valve. It's not necessary. Here's the finger of a glove. You could put a hole in the finger, run the Gelco through the glove finger, and it would act as a flutter valve. Again, not necessary. And then here's just some stuff to prep the site itself. So you're going to expose the chest and identify the landmarks, palpate for the angle of Louis, which is across the second rib, and then you want to locate the third rib, which would be the rib below the second, mid-clavicular line. Cleanse the site, take your 14 or 16 3-inch, at least 3-inch needle over the top of the rib, because running along the bottom is a nerve and artery or vein, and you don't want to lacerate those. And then you bury the needle to the hub and remove the needle, leaving the Gelco in place. Now, if you've gotten through the skin and into the pleural space, pressure will be relieved and the lung will start to re-expand. Here they're attaching a Heimlich flutter valve or a tip of a glove, and again, that's really not necessary. Reassess breath sounds, respiratory status, vital signs. Everything should get better if they do in fact have a tension pneumothorax and you needle them. Hemithorax is a collection of blood within the pleural cavity. It's caused by blunt or penetrating trauma. You can bleed about 2 or 3 units of blood into one side of your chest. The blood will displace the lung and reduces space for gas exchange. The bleeding may be significant enough to cause hypovolemic shock, but either way, it's going to compromise ventilation. The patient's going to complain of an injury, but did not initially notice shortness of breath. Non-traumatic hemothorax is uncommon. In other words, just a spontaneous tear of a vessel inside the chest is just extremely uncommon. So there's going to be with a hemothorax, typically some sort of history of chest trauma. Auscultation is going to reveal decreased breath sounds in the lower lobes when the patient is sitting up, because that's where the blood is going to collect. You want to adequately oxygenate them and ventilate them, hook up all your monitors, and if necessary, immobilize their spine. Hemopneumothorax is both air and blood in the pleural space. It's usually caused by penetrating trauma, very similar signs to a hemothorax, and the treatment is very similar to a hemothorax as well. Watch for the potential for the development of a tension pneumothorax. So most protocols will tell you that, certainly if you suspect a pneumo/hemo or pneumo, you just needle both sides of the chest, or you needle the side of the chest where you think the concern is. Just like with a pneumothorax or a tension pneumothorax or a hemothorax, when you have a patient who has a hemopneumothorax, they're going to be short of breath, tachypneic, tachycardic, hypotensive, shocky. They're going to have crepitus because it is usually caused by penetrating trauma. So there may be a flail segment, subcutaneous emphysema may be present, breath sounds may be absent on the side of the hemopneumo, and there may be some hyperresonance on percussion. It's supportive. Treatment is supportive. They need surgery. We can't go in there and fix the bleeding that's occurring inside the chest. We can just support their airway, their breathing, give them 100% oxygen, gain IV access en route, monitoring their pulse oximetry, end-tidal CO2, and cardiac monitor. With a hemopneumothorax, they can develop a tension pneumothorax as well, so watch for signs of a developing tension pneumothorax. The patient's respiratory distress gets worse, the blood pressure drops, they become extremely tachypnic, their SATs drop as well, and these patients need rapid transport before they exsanguinate into their chest. Tracheobronchial tears can be the result of blunt or penetrating trauma of the neck or chest. That's going to cause respiratory distress, hypoxia, coughing up blood, subcutaneous emphysema. If the trachea or the bronchial itself is torn, there's going to be some bleeding. There's going to be some escaping of air into the subcutaneous space. With a tracheobronchial injury, the wound opens into the pleural space and produces a large pneumothorax. Complete transection of the tracheobronchial tree, there would be no communication with the pleural space at all. And the bleeding may be significant enough to cause shock, or the patient may be coughing up quite a bit of blood. If you suspect a tracheobronchial injury, I've seen a couple of these in my career, and they're impressive. One was a female who had almost like whooping cough, and she coughed and coughed and coughed so forcefully that she tore her bronchi away from her lung. She had significant bleeding, was coughing up bowls full of bright red blood when we arrived, and she did not survive the event. Therapeutic intervention would be rapid transportation. If you there's just no way of knowing where that transection is. Here they're making an assumption that you can intubate through the transected airway if you know where it's at, because the endotracheal tube is just going to go to the carina. So if the transection is, in the trachea between the larynx and the carina, putting a tube in there certainly would be beneficial. But if it's lower into the bronchioles, you're not going to be effective. Cardiac contusion, again, when you have a blow to the chest, you can cause a bruise to the heart. We see this in rapid deceleration injuries, impalement on the steering wheel. The sternum is displaced posterior, and the heart is compressed between the sternum and the spine. The history and physical is going to be varied, very nonspecific. They may have pain similar to an MI. They may have shock similar to cardiogenic shock, or that may be benign. Blunt cardiac injury likely also has additional abdominal injuries, skeletal injuries, and head injuries as well. Some other injuries associated with a cardiac contusion include your pulmonary contusions, pneumothorax, hemithorax, external fracture of the sternum, great vessel injury, and cardiac output reduction may manifest as shock. So if the heart's not working adequately as a pump, you're going to develop cardiogenic shock. The right ventricle is more likely injured than the left. The least specific sign of a cardiac contusion is sinus tachycardia. On ECG, because the right is more likely injured, if you see that rapid deceleration, blow to the chest, they've got some chest pain, sounds like heart, you hook it up and see a right bundle branch block, that would be a good indication of a cardiac contusion. Determine the mechanism of injury. What the steering wheel look like? Were they wearing their seatbelt? Did the airbag deploy? How fast were they going? How'd you find the patient? Therapeutic intervention is going to include rapid transport because they may need a cardiovascular interventionist. High flow oxygen. Treat the heart-related chest discomfort much like you would an MI. Fibrinolytics and aspirin are contraindicated in this particular case, but arrhythmias that may result as a result of the bruise to the heart, you would treat them just like you do for ACLS. Now, pericardial tamponade is accumulation of blood in the pericardial space. Blood is a liquid. Liquid is non-compressible. It takes 300,000 pounds per square inch to compress liquid 1%. So when liquid accumulates in the pericardial sac, something has to give. The sac itself will stretch a little bit, but ultimately the pressure gets put on the superior and inferior vena cava, which are low pressure vessels, and those collapse, decreasing preload, dropping cardiac output, and leading to shock. Further compression will actually compress the heart to where it cannot beat at all. You'll see a classic triad with the pericardial tamponade. You'll see distended neck veins, muffled heart tones, and the narrowing of pulse pressures. The systolic and the diastolic will get closer and closer together. At some point, the patient will become hypotensive, and you may see pulsus paradoxus on inspiration. When you increase intrathoracic pressure, which you do every time you inhale, that may be just enough, in addition to what's going on in the pericardial sac, that may be just enough to take pulses away. And then when you exhale, you get the pulses back. Cardiac rupture is an acute traumatic perforation of the ventricles. It occurs in high-speed motor vehicle collisions. It is the most common cause of death in non-penetrating cardiac injuries. 1/3 of those who die have a multiple chamber rupture, both atrium and ventricles, and 1/4 rupture their ascending aorta. So the aorta, as it comes right out of the heart, is supported by the ligamentum arterioso or arteriosum, and the ligamentum arteriosum acts like a cheese grater. When the rapid deceleration, the weight of the heart hurls it forward in the chest, and that ligament that supports the heart in the chest just slices right through the aorta, and the patient will bleed to death in about a minute. The epidemiology and demographics of cardiac rupture, it is almost always immediately fatal. It's found in 15% of fatal thoracic injuries. Most survivors, if they survive, do so because the only thing that ruptures is the atrium. They also have other multi-system injuries common with this. They're going to be hypotensive, tachycardic, distended neck veins, cyanosis to the head, neck, arms, and upper chest, much like a traumatic asphyxiation, unresponsive, distant heart sounds, and presence obvious chest injuries. If they're still alive, you're going to oxygenate them, ventilate them, do all these things en route with rapid transport, pulse oximetry, capnography, IV access, cardiac monitor. Injury to the 8 great vessels. You can have an aortic rupture. The thoracic aorta is the most common vessel injured by blunt trauma. 80 to 90% occur in the descending aorta, distal to the left subclavian artery. It may also be associated with pericardial tamponade. You can have aortic valve tears. It may also be associated with myocardial contusion and other coronary artery injuries as well. And again, with an aortic rupture, people rarely survive this. They usually die right there. High-speed motor vehicle deceleration. You can have all types of injuries in addition to the aortic rupture. Pulmonary contusions, head injuries, broken bones, maxillofacial trauma, abdominal trauma. Symptoms of an aortic rupture, pain between the shoulder blades, pain in the retrosternal area as blood accumulates in the retrosternal space. They'll be short of breath. They may have stridor or hoarseness, difficulty swallowing, may have extremity pain because the aorta may dissect or blood supply may stop down each arm. So they may have not only pain, but may feel like their arms are numb. Hypertension will cause an aortic rupture as well. So it's important that in patients that are hypertensive, that is the number one cause of a aortic dissection and a non-traumatic aortic rupture. Therapeutic interventions, again, most of these people die right there. If they're still alive, treat the hypotension, rule out a tension pneumothorax, tamponade, give a fluid bolus, and rapid transport. Injury to the vena cava or pulmonary vessels are also associated with injuries to the chest, abdomen, or neck. The injuries can be to the vena cava, the superior vena cava, the inferior vena cava, the pulmonary arteries, or the full 4 main pulmonary veins. These type of vessel injuries, when you injure the great vessels, they're often accompanied by massive hemithorax, hypovolemic shock, and cardiac tamponade. Diaphragmatic injuries occur when pressure is put on the abdomen. Blunt force trauma to the abdomen may cause the abdominal contents to herniate into the chest. So you can have a diaphragmatic herniation. You'll hear bowel sounds in the chest. Typically, if it occurs, it's more prominent on the left because the liver protects the diaphragm on the right. Esophageal tears, usually not an isolated injury all by itself. Cervical esophageal injuries are more common when we're talking about chest trauma and thoracic trauma. The trachea is more commonly injured than the esophagus. In non-traumatic patients, you can have a Mallory-Weiss tear from very forceful vomiting. We see esophageal disruption or Mallory-Weiss tears, particularly in bulimics who purge a lot. The purging secretes lots of acid in the esophagus, or people with GERD, and it weakens the connection between the esophagus and the stomach, and with forceful vomiting, they tear it. They're going to have a history of neck pain, difficulty swallowing. They may be coughing. Their voice may change. They may be throwing up blood. They may not be able to flex their head because it'll hurt as they stretch the esophagus. There may be some crepitus, maybe some stridor, maybe some airway compromise. Patients with esophageal injuries, because they almost always involve the trachea as well, it's an airway issue. So if you suspect as a result of trauma that the patient has an esophageal injury, also suspect that their trachea is injured, and you need to do a rapid sequence intubation to secure that trachea if they become completely obstructed, a surgical airway. All right. With that, I know that was quick, but thoracic trauma is pretty straightforward. And if you have any questions, you know how to get a hold of me. So with that, I will talk to you soon.